Almost everything we know about human health comes from the study of men and male animals, even male cell lines. For centuries, medicine has studied men and assumed it applied to women and other people with a uterus too. Assumed. But they didn't know, and they still largely don't. I want to talk to you today about what medicine knows and doesn't know about female biology, what the consequences of that knowledge gap are for women and gender diverse people, and what we can do about it. I'll first address what medicine doesn't know, and then I'll walk you through what medicine has historically thought it knew, why this matters, and what we can do about it. And because there must always be hope, I'll address the great irony of long COVID and its potential to change things for the better. First, what medicine doesn't know about people with a uterus. We literally know less about every aspect of female biology compared to male biology. These are the words of Dr. Janine Austin Clayton, the Director of the Office of Research on Women's Health at the US National Institutes of Health. Why is this? Because medicine has traditionally not studied women or female animals, as I just said. It wasn't until 1993 that women were included in clinical trials, and it only occurred then because of the hard-fought campaign led by women and their allies. Until then, drugs were studied in men, then sold to women and gender-diverse people on the public market. Of the 10 prescription drugs taken off the market by the US drug regulator between 1997 and 2000 due to severe adverse effects, 8 caused greater health risks in women. A 2018 study found this was a result of serious male biases in basic, preclinical, and clinical research. So why? Why is it that medicine has not traditionally studied women or female animals? 2 excuses come up. The first is the more prevalent, and it applies to both preclinical, that's the study of animals, and clinical, that's the study of humans, studies. And it's that hormonal cycles in people with a uterus or estrous cycles in female rodents may introduce too much variability into results. And therefore it's just too expensive to include women, other people with a uterus, and even female animals. Leslie Lawrence and Beth Winehouse summed up this faulty reasoning perfectly in their 1994 book, Outrageous Practices. They wrote, "It defies logic for researchers to acknowledge gender difference by claiming women's hormones can affect study results, for instance, by affecting drug metabolism, but then to ignore these differences, study only men, and extrapolate the results to women." By the way, all human bodies, including cisgender men's, experience hormonal fluctuations. The second reason given is that the trial may affect a woman's ability to bear children. Again, this is a claim that doesn't stack up under scientific scrutiny and suffers from the same lack of logic as the previous excuse. Let me explain. This claim came up after the thalidomide tragedy. This was a drug prescribed to pregnant people around the world, mainly in Germany, the UK and Australia, but others including the US too. It was prescribed for morning sickness. It resulted in 10,000 children being born with severe birth defects. It was after this that women of childbearing age were excluded from clinical trials. However, this drug was not tested on women or any pregnant person before being sold to them. It was not even tested on pregnant animals. This immense human tragedy was not caused by testing a drug on women and hurting the participants. It was a tragedy caused by a failure to adequately test the drug at all and then sell it on the mass market. After this tragedy had taken place, the drug was tested on pregnant animals, and guess what? It was shown to have fetal toxicity. So if this drug had undergone any sort of rigorous testing on animals, it would have found the dangers and not proceeded to human trials. It would not have been sold on the mass market. The knowledge gap created in the 30 years of female exclusion because of this misplaced logic is untold. In her book, Doing Harm, Maya Dusenbury summarised some of the more ludicrous clinical trials that have taken place while excluding women. Some of my favourite examples include a study that looked at whether estrogen could prevent heart disease that only enrolled men, And guess how many women another trial enrolled that considered whether obesity affected breast cancer and uterine cancer? 0. Today, women still make up only 41% of people in clinical trials, even in illnesses where they are primarily affected. I haven't been able to find any really reliable data on how many gender diverse people are included in clinical trials today, but I do believe that work is being done. In animal studies, the picture is even more depressing. In the time since women have been included in clinical studies in 1993, the number of female animals being studied has decreased. A 2009 study found male bias in 8 of 10 fields of biological research. The authors found, and I quote, "Underrepresentation of females in animal modes of disease is commonplace, and our understanding of female biology is compromised by these deficiencies." They also found that the idea that female animals were more variable than males, are too troublesome for inclusion to be without foundation. In 2016, recognising this problem of male bias in preclinical research, the US National Institutes of Health, which is the world's largest medical research funding body, mandated all research should include female animals and analyse results for sex differences. A 2020 follow-up study on sex bias in biomedical research to that 2009 study I just mentioned found that while there was an increase in inclusion of female animals in studies, researchers were still not analysing results for sex differences. So the gap in knowledge still exists. What has medicine traditionally claimed to know about people with a uterus? For a long time in medicine, it was assumed that women were just men with a womb. Woman's difference has always marked her as inferior. The uterus, the most obvious mark of difference, was once considered to be the source of all disease. Then, in the 17th century, the source of women's illness shifted from the uterus to her weak nervous system before shifting back to the reproductive system, this time to the ovaries and clitoris. After the discovery of sex hormones in the early 20th century, it shifted again, this time to her raging hormones. Through all these shifts in blame, society's distrust of women remained constant. And so when they presented with complaints that seemed unique to women, the womb was just assumed to be the culprit. Then the nervous system, then her ovaries, sometimes her clitoris, and then her hormonal cycles. All of these functions revolved around her ability to procreate. Because she had a womb, she should use her womb, the assumptions went. Any cluster of symptoms that women seemed to present with that men didn't came to be blamed on a disease called hysteria, a word that literally comes from the Greek for uterus. Theories that symptoms were caused by a woman not fulfilling her role as a good wife and mother prevailed in medicine for centuries and linger today. Multiple sclerosis, migraine, lupus, endometriosis were all at one time written off as hysteria and causes assigned to the individual. A woman could be told that her illness was caused by too much sex, not enough sex, too much masturbation, using her brain too much, having a type A personality, being a career woman, delaying pregnancy, being too anxious about her health, working too hard, being stressed, or being overweight. Heinous crimes were committed against women in the name of curing hysteria. Clitorises were cut off, ovaries removed without anaesthesia, extreme forms of bed rest and talking therapy were prescribed. Leeches have been attached to cervix and vulvas. Nice-smelling herbs have been placed at the vulva, while foul-smelling herbs have been placed at the nose and mouth to coax the womb back into place. If you can't tell which of these examples is from the modern world and which from the ancient, that's on purpose. Because in spite of radical advances in modern medicine, the myth that women can't control their bodies or emotions and that this brings on debilitating illnesses persists in doctors' rooms around the world today. So much of what medicine purports to know about women's health comes from assumptions, theories based in prejudice about women's place in the world, and even old wives' tales. So what are the consequences? Well, they're huge. I put the consequences into two main categories. The first category I call misdiagnosis, late diagnosis, and death. The second category I call diseases formerly known as hysteria. Let's talk about misdiagnosis, late diagnosis, and death first. In 1990, the Office of Research on Women's Health was formed in the US in response to a campaign to include more women in clinical trials. The office's first agenda-setting paper in 1991 noted a pervasive sense in the research community that many of the health issues of women are of secondary importance, especially those that occur solely in women and those that occur in men and women, but have already been studied chiefly in men. Let me translate this for you. It's bureaucratic jargon that basically means diseases that mainly affect people with a uterus are boring and not that important, and we don't want to study how diseases work in women where we already have a lot of knowledge from studying men. Guess what the result of this gender bias is? Women and other people with a uterus are diagnosed later than men in more than 700 diseases. Women wait longer for pain medication than men. They are more likely to have their physical symptoms ascribed to mental health issues. They are more likely to have their heart disease misdiagnosed, become disabled after a stroke, suffer from illnesses ignored or denied by the medical profession, and they also wait longer to be diagnosed for cancer. Let's look at heart disease. Heart disease is the leading cause of death among women globally. It's traditionally been thought of as a men's disease, though, and this has led to deadly consequences for women. In 2004, just for an example, 7.4 million women over the age of 60 died of cardiovascular disease. How many men died of this men's disease? 6.3 million men. Almost everything known about heart disease and its treatments has been learnt from studying men. So doctors have been trained to recognise the signs and symptoms of heart attacks, cardiovascular conditions and strokes in men. But heart disease can work differently in women to men. It can even work differently among men. I spoke to the cardiothoracic surgeon Dr. Nikki Stamp about this problem. She told me there's this difference in biology between a man's heart attack and a woman's heart attack. What this means is that the symptoms can be different. Our diagnostic tests may not be geared to pick up the problem, and also our treatments probably don't work as well for that different biology. When sufferers present with so-called atypical symptoms, they're often misdiagnosed or sent home with anxiety or some other problem. A 2018 study published in the Medical Journal of Australia found that women were half as likely to be treated properly for a heart attack as men and twice as likely to die within 6 months. Now, that only looked at a very specific and quite deadly form of a heart attack, and it was done in Australia's leading hospitals. Let me remind you, that was only in 2018. A 2017 study in the US found that 22% of primary care physicians and 42% of cardiologists said they felt extremely well prepared to assess women's cardiovascular risk. Let that sink in. Fewer than half of heart specialists feel very well prepared to assess whether a woman, half the population, is at risk of some kind of heart disease. And that's not all. Just last month, a major new study of 400,000 Europeans found that nearly 12,000 women in the UK have missed out on appropriate care for their heart attack over the past 2 decades, and some have died as a result. Why? Because the current scoring system for heart attack risk, which is applied to both sexes, was developed only using data from men. The research by experts at Imperial College London and the University of Zurich found that 5% of women who suffered a heart attack were wrongly classified as not at high risk of death. Some will have missed out on life-saving emergency treatment as a result, such as surgery to restore blood flow to the heart or clot-dissolving drugs. As I said before, some men also experience these atypical symptoms. So guess what? Recognizing the whole range of symptoms of heart disease benefits all humans. Who could have guessed? If even doctors aren't recognising women's risk of heart disease, it goes without saying that many women and gender diverse people don't know they're at risk either. Many delay seeking treatment because they think they can't be affected. They don't recognise there are symptoms as heart disease. So people who have had preeclampsia, gestational diabetes, or high blood pressure during pregnancy are at particular risk for cardiovascular disease and stroke. Yet many are not aware of this and they're not being warned by their healthcare professionals. If they can get it so wrong on such a big killer, imagine what's happening in diseases that have not had the kind of research dedicated as heart disease. This is the category I call diseases formerly known as hysteria. These are diseases that predominantly affect people with a uterus, and these are the illnesses that have not received a lot of research funding or attention. Many have been written off as hysteria for centuries, and some still are. Let's first talk about autoimmune conditions such as rheumatoid arthritis, lupus, and multiple sclerosis. About 78% of people with autoimmune conditions are women or people assigned female at birth. They occur when our immune system, which defends the body against bacteria, viruses, and other germs, turns on itself and starts to attack its own healthy cells, tissues, or organs. Autoimmune disease is a leading cause of death and disability in women and other people with a uterus globally. Why? Well, science doesn't know for sure, but we do know that the male and female immune systems work slightly differently. Female immune systems tend to be more flexible, they produce more antibodies, and are just better at fighting infections. This is evident from the earliest days of life, with premature babies assigned female surviving better than males. The upside is women tend to survive infections better than men. The downside is that they often don't return to their normal levels of health. They survive, but they're sicker. This greater flexibility of the immune system means it can also turn on itself, and this is probably the reason women are more prone to autoimmune diseases. There are about 100 different autoimmune diseases and no cure for any of them. While treatments have greatly improved in the past 2 decades, there is still so much work to be done. People with a uterus around the world face lengthy delays in diagnosis for autoimmune conditions. Almost half the women eventually diagnosed with one of these diseases will have been told by their doctors that they're hypochondriacs or too concerned with their health at some point on their journey to diagnosis. Multiple sclerosis was once called hysterical paralysis, and even though it was way more prevalent in women, men were more likely to be diagnosed with a serious neurological condition. It was even considered to be more common in men because, as I just said, men, when they presented with symptoms, were diagnosed with an organic condition. When women presented with those same symptoms, they were kind of written off or diagnosed with hysteria or some other kind of mental illness. It was only by accident of technological advancement that MRIs were able to pick up the physical proof of MS, that medicine realised it was 3 to 4 times more common in women. Chronic pain is another condition that predominantly affects people with a uterus. About 70% of chronic pain patients are women, but 80% of pain studies have been conducted on men or male mice. As the researcher Mark Hutchinson said to me, this is just useless. He's been one of the researchers to discover that chronic pain acts differently in female versus male biology. There is nothing that tests on human men and male animals can tell us about the experience of chronic pain in people with a uterus. And yet that's where most of the research to this day has gone. What's been thrown out that could work? We just don't know. The disparity in pain in men and women lasts throughout their reproductive lives. As children, boys and girls experience roughly the same levels of pain. But once girls reach adolescence, the number of them experiencing pain that lasts more than 3 months, that's what we call chronic pain, is leaps and bounds ahead of the boys. Almost all the major chronic pain conditions affect more women than men, including endometriosis and vulvodynia, obviously, but also rheumatoid arthritis, migraines, ME, chronic fatigue syndrome, and fibromyalgia. While chronic pain affects the same number of people as cancer, heart disease, and diabetes combined, figures from the US show it receives 95% less research funding. The historic report Relieving Pain in America found that 4 in 10 adults live with chronic pain disorders, and they recognised a cluster of pain conditions that frequently co-occur solely or predominantly in women. They were later given a name by the US Congress, and they were called chronic overlapping pain conditions. These 10 conditions are endometriosis, vulvodynia, fibromyalgia, chronic fatigue syndrome, which is also known as myalgic encephalomyelitis, interstitial cystitis or painful bladder syndrome, temporomandibular joint disorders, that's jaw pain, irritable bowel syndrome, chronic tension time headache, chronic migraine, and chronic low back pain. All of these conditions are beset by misdiagnosis, lack of coordinated medical care, and a sparsity of safe and effective treatment options. But doctors are not taught about this gender bias in their training. They are not taught that there will be women and gender diverse people sitting in their waiting rooms with generalised symptoms of pain, fatigue, brain fog, who they can't help because medicine has not bothered to study them. They are trained to see them as anxious and difficult and to blame for their own poor health. All of this leads to a poorer quality of life. Often when I'm complained about gender bias in medicine, men will reply that women live longer, and so therefore men's health is the real problem. Women may live longer, and I'll get to that in a minute, but men now have overtaken women in active, healthy years. That is, if you count the number of years you live in a healthy way and an active way, and you can go about your life normally, men have overtaken women in the last decade. And a recent study by academics in Denmark has even called into question whether women do actually outlive men after all. According to a report published in The Guardian, the study, which was published in the BMJ Open Journal, examined data on the lifespan of men and women across 199 countries for 200 years. It concluded that men have a high probability of outliving women, especially those who are married or have a degree. The authors said, males who are married or have a university degree tend to outlive females who are unmarried or do not have a high school diploma. The analysis also found that in developed countries, the probability of men outliving women fell until the 1970s, after which it gradually increased in all populations. But let's not despair. There is hope on the horizon. The greatest scandal of long COVID is that it was entirely predictable and we should have been prepared. We know more men die from infectious diseases and that women survive but do not fully recover. An old medical adage goes, men die quicker, women are sicker. Anyone who has studied ME or CFS knows that a portion of people, mostly women, have long-lasting post-viral illnesses that affect their ability to fully function. We know it happens after glandular fever, it happened after SARS, it can happen after the flu. But medicine has been so dismissive of ME/CFS, it has received negligible funding and a whole lot of stigma. If medicine had bothered to listen to people with this disease, they might have been prepared for long COVID. But some people were. They were patients with ME/CFS and the doctors and researchers who have devoted their lives to studying it. They reached out online to long COVID patients in the earliest days of the pandemic. Together, they lobbied. The sheer number of people suffering from long COVID can no longer be ignored. The effect on the economy and the health system cannot be ignored. More research funding than has ever been dedicated to ME/CFS has now been promised to long COVID research. And because most patients are women, they'll be studying immune system effects in both sexes. And they'll be looking at how the immune system interacts with both infectious and non-communicable diseases. This research may unlock some of the mysteries surrounding many chronic pain and other chronic illnesses that have long been neglected in medical science. So what can we do about all of this? We can do some things. First, we can smash the stigma. For too long, it's been taboo to talk about periods, pain involving vulvas and vaginas, and painful or unenjoyable sex. We must start to talk openly about these things so we have an understanding of the boundaries of normal. It is normal to have pain with your period. It's not normal for that pain to be so severe that it interferes with your ability to do the things you want to do month after month after month. It is common for women to have pain during sex, but it's not normal and it doesn't have to be that way. One study found that almost half the delay in diagnosis for endometriosis was down to a failure to report symptoms. If you don't know it's not normal, why report it? Please talk to people about these issues, and not just among women and gender diverse people. We need to make these conversations common in our society. We can get organised. We need a global campaign for gender justice in health. Only well-organised and sustained campaigns can make a difference in changing medicine. But we have seen it happen often enough to know it works. Breast cancer patients were once told it was a career women's disease, or that they got breast cancer because they delayed childbirth. But women and their allies changed this by organising, raising a lot of money, and then demanding a say in the kind of research that money funded. This is important because not all research is created equal. Endometriosis, for example, has received a boost in funding since awareness around it has increased in the past decade. But not all of it is that helpful. One study I reported on at The Guardian rated the attractiveness of women compared to the severity of their disease. I'm not joking. The study was titled Attractiveness of Women with Rectovaginal Endometriosis, a case control study. It was first published in 2013. It's now been retracted, but it was defended by the authors and the journal for a long time, and some still are defending it. The study concluded women with rectovaginal endometriosis were judged to be more attractive than those in the two control groups. Moreover, they had a leaner silhouette, larger breasts, and an earlier kotarchy. Kotarchy is the age at first sexual intercourse. The women taking part in the study had not given their consent to be judged for their attractiveness and didn't know it was happening as part of their medical consultations. The authors asked the women about their sexual history. They measured their body mass index, waist to hip ratio, and breast to underbreast ratio. Only Caucasian, their word, women were selected to be included in the study. While some bodily characteristics can be associated with certain diseases and symptoms and should be studied, this was not what this study measured. It subjectively rated women's attractiveness without their consent. This is a very good example of why patients must have a say in the kind of research that's commissioned. There was a case in the 90s where the US Congress devoted some research to ME/CFS, and it was just misused, and other things were studied instead because the researchers didn't think it was worthwhile. When they did do studies, they studied things like the types of personality of people who get ME/CFS. We need to demand more resources for research that looks at female biology, both in animals and humans. We need to ensure gender diverse people are included in this research and results are analysed for difference. Finally, we can all make sure the information we share online is credible. I've seen many well-meaning people spreading misinformation or misinterpreted information online. We have to listen to the experts. While it's true medicine has failed us in some ways, it's not true that all doctors and nurses are bad people that we can't trust. We have to believe in science. There are many experts on our side. We have to listen to them and work with them to spread factual information that is backed by evidence. And we have to call out when not enough evidence exists. Medical science is not perfect, but it is the only hope we've got. Thank you so much for listening. I hope you enjoy the rest of the conference.